Hello, I'm Dr. Jeffrey Niezgoda. I'm the Chief Medical Officer for Wound Care for Kent Imaging. My story began in undergrad at the Air Force Academy, and I was fortunate enough to be selected to attend the Uniformed Services University for medical school. I graduated and went on to become trained as an emergency medicine physician, and during my time in the military, I was able to experience flight surgery and the hyperbaric environment. And I quickly developed an interest in hyperbaric medicine and did a fellowship in hyperbaric oxygen therapy and wound care while I was in the military. When I left the Air Force, I was offered a position in Milwaukee to walk in Dr. Eric Kinwald's footsteps as the medical director for the hyperbaric and wound care program at St. Luke's Medical Center. I spent almost 20 years there with that program. After I left St. Luke's, I decided to go into private practice in what's called a Site 11 wound care clinic, which is a non-hospital based program. This program allowed me the opportunity to do what I dreamed about doing for a number of years, and that's taking care of patients. We had a full service wound care clinic, including hyperbaric oxygen therapy at AZH. One of my interests in wound care all the way along has been looking at new technologies and determining whether these new technologies had actual applications in the care of patients with chronic wounds. While I was at AZH, I was introduced to Kent Imaging and the snapshot technology, and I became infatuated with near-infrared spectroscopy and really started exploring this technology and the application to the management of patients with chronic wounds and also in the hyperbaric setting. And I was very impressed with the technology and used it extensively in my practice. I was offered a position as a chief medical officer with Kent Imaging, and based on my incredible interest and great experience with the technology, I decided to come on board with Kent Imaging, and I've been serving as their chief medical officer from a wound care perspective, working with my colleague, Dr. Glyn Jones, from a surgical standpoint, and we've collaborated together to take the operations of the company, Kent, and try to translate that to the clinical setting in both surgical realm as well as wound care. And it's been a great experience working with a great team of people, taking a great technology to the patients, and I think we have really been able to advance the science of wound healing and the applications of near-infrared technology to our patients.
Hello, I'm Glyn Jones. I'm the Chief Medical Officer for Plastic Surgery for Kent Medical Imaging, and I was involved in coming over to the United States to the Emory Clinic about 30 years ago from Cape Town, South Africa, and was involved very heavily in breast reconstruction as my primary interest in breast surgery, as well as complex wound management and the management of soft tissue sarcomas with the orthopedic services. And I spent 15 years at the Emory Clinic and then moved to Peoria, Illinois to join two of my residents in private practice. And it was there as a professor with the University of Illinois College of Medicine that I was introduced to imaging perfusion technology in the form of the SPY and ICG technology back in 2007. And I was able to get the first two SPY cameras in the country and had a lot of experience with that over the next 12 years or so, and found it immensely helpful in helping to develop the concept of immediate breast reconstruction for cancer patients. As a result of that technology, I saw some limitations. It was very expensive, it was invasive, took a lot of time, and the analysis took a lot of time. And it was then that I was introduced to the Kent technology, multispectral imaging, about 5 years ago. And I started working with that technology in my practice, and it ultimately became the replacement for ICG-based technology in my practice. And I was able to use it to advance my interest in prepectoral immediate breast reconstruction with direct implant insertion, and it really revolutionized my practice at that time. And over the years, as I developed more confidence with the technology and I was able to speak about it at meetings, I ultimately was approached by the Kent team to join their team as the Chief Medical Officer for Plastic Surgery, and I was introduced to people like Jeff, and we had a tremendous team to work with here, with a very dynamic physics and science team and a research group that we could work with, and that has brought us to the point where we are today, with a technology that I think is really changing the face of both surgery and wound care and so on for our patients, and providing a very cost-effective technology for physicians to use both in the operating room, in hospital settings, in clinics, and so forth. So I'm very excited to be here as a part of this team and work with my colleagues here, and look forward to a future where patient care is advanced tremendously.
We're continuing to discover applications for near-infrared technology, and the snapshot not only is used to evaluate wounds, but all aspects of that patient that does present with a chronic wound. For example, we use it in the hyperbaric realm. And most recently, we've identified that we can use a snapshot near-infrared technology to actually help in the screening of patients with peripheral arterial disease. Many patients with chronic wounds will have arterial insufficiency, compromising their healing. And we have been sort of hamstrung in the evaluation of those patients with tests that are very difficult to use, very labor intensive, with very poor results. For example, transcutaneous oximetry, 45-minute examination, fraught with problems, and really doesn't give you a real good handle on how to evaluate that patient. ABIs are notoriously inaccurate and just don't do a very good job of screening for patients. We have discovered that using snapshot with a simple leg lift maneuver, a provocative mover, if you will, can stress that extremity, and with imaging in just a few minutes, when that patient is in the supine position and then once elevated, those changes in oxygenation and tissue perfusion can demonstrate to the clinician very quickly those patients that are at risk for arterial insufficiency. And we can actually subdivide these patients into a mild, moderate, and severe risk of arterial disease. And so what that does is allows us to do bedside screening of these patients with a real quick examination, and not only make decisions as to the degree of their disease state, but then make appropriate referrals very quickly to our vascular colleagues for further evaluation and potential intervention. I can heal just about any wound if that patient has an adequate blood supply. Blood delivers oxygen. And so without addressing that problem, these wounds will stagnate forever. So by incorporating snapshot into my wound care practice, I can provide earlier screening, earlier detection of disease that may be compromising that wound healing, and probably more important, earlier intervention to prevent that patient from losing their limb to the complications of a chronic wound via an amputation.
In the emergency room, I think physicians are challenged when they see ischemic limbs presenting, whether it be due to thrombotic or embolic phenomena, patients with peripheral vascular disease. And now we're seeing an increase in the number of vascular incidents associated with xylazine, the street drug tranq, being added to things like fentanyl. And we're seeing really significantly increased numbers of patients coming through the emergency rooms with embolic and thrombotic phenomena, resulting in gangrenous fingers, lower extremities, and so forth. And for the emergency room physician, being able to have a device like the snapshot camera to assess the oxygenation and perfusion to an extremity or an affected digit, for example, may enable them to get faster access to a vascular surgeon or an interventional radiologist who could then go ahead and perform a thrombectomy, embolectomy, or a clot dissolution procedure to help save an extremity in those catastrophic situations. So I think there's certainly applicability for this in the emergency room, and I don't know what your thoughts would be, Jeff, having worked as an ER physician.
Glenn, I couldn't agree more with you. I think looking at my emergency medicine training and my experience in emergency medicine, one of the areas that is poorly taught during emergency medicine residency is wound care. As emergency medicine physicians, unfortunately, we don't really understand wounds and don't do a good job of assessing them. And I also agree regarding patients with limb ischemia and limb threat.
Right.
It's just not something we do a good job of. I think the snapshot device really can go a long way into bridging that gap in education and providing the emergency medicine physician with some very good objective data to how hypoxic is that wound, how ischemic is that limb, and can help facilitate that triage that happens in the emergency department. Does this patient need to be admitted to the hospital or potentially just referred for vascular evaluation the next day or two? I think the default position for most emergency physicians is, well, I don't want to take a chance, and so we admit these patients to the hospital. Whereas if you have an image that shows reasonable perfusion, obviously some compromise, but compromise that is not necessarily limb threatening, those patients can be triage staged and referred the next day or 24 hours, 48 hours down the road for a more formal evaluation and workup. What patients like to be admitted to the hospital. So I think that if we could prevent them from being admitted to the hospital and improve the chance of providing limb salvage and limb interventions that could be limb saving, I think the device really has significant efficacy and efficiency in the management of these patients.
And I think too, just to add to what Jeff has said, this device is so portable. It's very easy to have several of these scattered throughout the emergency room, and you can just pick up a device, take a quick picture. It can be uploaded into the electronic record eventually, and it facilitates that immediate assessment, as you say, which gives you a little more confidence to say, should I or should I not admit this patient, or is this an acute vascular emergency that needs an intervention from a physician or surgeon or radiologist.
Yeah, absolutely. And we talked a little earlier about the use of near-infrared spectroscopy for peripheral arterial disease screening, PED screening. This is you're exactly right. It's a bedside test that can be done. The patient can be evaluated very quickly in the emergency department and decisions made there on the spot at the bedside that again can be very cost effective and enhance overall patient care. So Glenn, you're very familiar with technologies. I have used technologies all my career. We know the impact that technologies can have on patient care clearly. I think this is one of those technologies that can be a real game changer. And the reason I believe that, and I'm interested to hear your thoughts, is you can use it immediately for a bedside assessment and make decisions essentially on the fly as you're managing that patient. Is there an intervention that you're doing that's making sense and working for the patient, or is it not working? And maybe we need to move in a different direction. That kind of decision making, I think, really enhances the efficiency of patient care. Certainly, from a patient care standpoint, if these patients can have decisions made quickly and appropriately, they waste less time, less money. So, I think the impact of this technology on the way we do business in the wound care clinic, certainly from a vascular screening standpoint, really makes a difference. It can be a game changer for clinical practice.
Absolutely, and I think one of the things that I've really liked about this technology, Jeff, is its cost effectiveness. So many of the preceding competing technologies have been tremendously expensive, tied to the operating room, so you're tied to an OR laparoscopic tower or a computer stand. You're invasive, And those are all detractors, whereas this technology is very low cost, relatively speaking. It's non-invasive and it's portable.
Right.
You can take it from the OR to the ICU to the floor. You can use it in an office setting. And one of the things I think that people don't talk about is I've always been concerned about the lack of applicability of technology like this to the rest of the world.
Mm-hmm.
We have a lot of money available in this country, or we did have, and the demand on healthcare dollars is constricting. Everybody's applying for a limited pie, and if you go overseas, like to Europe or even worse to the third world, people look at you like you've crawled out of a cheese when you say, "I've got this technology that costs $250,000, and it's tied to a laparoscopic tower or whatever." They don't have that money, particularly like in Europe, where you have a set number of healthcare dollars applied to a given procedure and outcome, like breast reconstruction. There's only a certain fund of money that's given to that. And if that pie is cut up by other technologies, you may eliminate any resources available for the actual procedure itself. In the third world, for example, where people simply don't have much money, something like this, I think, can be really effective in supplying an effective technology at relatively low cost to a large number of people who would otherwise not have anything like that to benefit.
Yeah, absolutely. We've heard over and all, at least I've heard it for the last 10, 15 years in clinical practice, is, have to do more with less.
Correct.
And I think this is a great example of having a technology where you can really get super amount of information,
Right.
Information that's clinically changing from a decision and management standpoint at really cost-effective pricing.
Right.
And you're right, it doesn't cost $250,000, and it can't be done at the bedside. Many times incorporated into the practice flow and strategy for pennies.
Right.
And, that really enhances, I think, the overall cost of care.
Agreed.